Good afternoon. This is the second part of the revision video, and it will be mainly covering the part on diabetes. But before starting our explanation of diabetes mellitus, we will first finish the symptoms of the urinary disorders that we started in the first part of the video. The fifth symptom. Is it the fifth? I'm not sure because it's covered by the toolbar. So anyways, the first symptom we are going to discuss on this video is hematuria. And as the name indicates, hematuria, hem means blood and uria means in urine. So if I ever ask you, the first type of question that you might be asked as usual is, what does this term refer to or define hematuria? So you can say that hematuria is the presence of blood in urine, or more specifically, hematuria is the presence of red blood corpuscles in urine. So this is the first question. As usual, we can say define, or what does the term hematuria refer to? Then I might ask you about, for example, the causes of hematuria. So of course, I never ask you about the causes of hematuria in general, but I might specify, for example, discuss the causes of painful hematuria. So when you have painful hematuria, this means that the blood does not only suffer from hematuria, but he also suffers, or she also suffers from pain together with the blood in urine. So there is blood in urine, and meanwhile there is painful micturition. So the causes of painful hematuria. Causes of painful hematuria include mainly stones in the urinary system, whether they are renal stones in the tissue of the kidney itself, okay, or they are ureteric stones. So the main cause of painful hematuria are the renal stones. So we should have here, there is an error or an inaccuracy in the numbering of the causes. So we can actually say that the causes include, number one, stones, okay, and the stones can be renal stones or ureteric stones. If the stone is here inside the renal tissue itself, then it is a renal stone. So what is a renal stone? A renal stone is a stone that lies within the kidney, or it might be a ureteric stone lying in the ureter. So what is a ureteric stone? It is a stone that has developed in the ureter itself, for example, a stone here. By renal stones, we mean stones that have been formed, for example, inside the renal pelvis, as we said before, or inside the major calyces, or inside the minor calyces. And in such a case, as we said, what is the major risk that is related to those renal stones that lie in the renal pelvis, or in the major calyces, or in the minor calyces, I mean in the renal tissue itself? It is that these stones may remain dormant for years. And by dormant, I mean asymptomatic, meaning that the patient does not develop symptoms, and he might be shocked after many years upon discovery of the very sad fact that he is suffering from renal failure. But usually the ureteric stone shows symptoms, and these symptoms are colicky pain and bloody urine. The second cause of painful hematuria, as we said before, is bilharziasis. And bilharziasis actually is a parasitic disease, meaning that it is caused by a parasite, a living organism that causes a disease to human beings, and it is the bilharzia worm. The bilharzia, there are course, female bilharzia worms and male bilharzia worms. They reproduce inside the human body and they produce eggs. They reproduce near the liver, in blood vessels near the liver. The female lays its eggs in the circulation or in the blood vessels around the liver, and then they find their way to the urinary bladder, where the eggs are deposited. Okay, so I might ask you to justify. I might ask you question 2, justify there is hematuria associated with bilharziasis. Why? Patients with urinary bilharziasis, because there are two types of bilharziasis. There is intestinal bilharziasis, which we will not study here, of course, and there is urinary bilharziasis, and of course, it is the urinary bilharziasis that is characterized by blood urine. So justify hematuria that is associated with bilharziasis. This B with a dash on it indicates bilharziasis. So it's just because the eggs in bilharziasis are deposited by the female in the wall of the urinary bladder, and these eggs have spiny walls. So you have eggs, and these eggs are spiny, and it is the spine that attaches to the bladder mucosa. It is the spine that attaches to the bladder mucosa, and when the spine attaches to the bladder mucosa, there is rupture of some blood vessels in the bladder, rupture of blood vessels in the bladder, and this leads to bleeding. Okay. Now, there is another category of hematuria, which is painless hematuria, meaning that the patient only has blood in urine. So you might simply be asked about the causes of painless hematuria. If I ask you a general question about hematuria, the causes of hematuria, so you have to classify the causes of hematuria into painful, which are the stones and bilharziasis, and painless. But most of the time I specify in order to avoid very long answers. So most of the time I specify, I ask about causes of painful or causes of painless hematuria. Causes of painless hematuria include two broad causes, which are glomerulonephritis and systemic bleeding disorders. I might ask you about glomerulonephritis, and this would be question number 4. I might ask you to describe the pathogenesis of glomerulonephritis. Describe the pathogenesis of glomerulonephritis. And as we have said before, pathogenesis means how the disease develops. But I might ask you the question in a different way, using different words, and I might ask you, for example, glomerulonephritis is considered an autoimmune disease. Glomerulonephritis is considered an autoimmune disease. And then at the end, I tell you, or I ask you to justify the fact that glomerulonephritis is an autoimmune disease. So how would we answer this question? First of all, we have to define what an autoimmune disease is, and this definition might be a question. So question number 5 might be, what's meant by, or what does the term refer to? So what's meant by glomerulonephritis? Or what's meant by, autoimmune disease? Auto, I might ask you specifically about the definition of an autoimmune disease. Of course, as the name implies, auto here means self. So how would we define autoimmune disease? An autoimmune disease is a disease in which your immune system attacks your own cells. So an autoimmune disease is a condition or a disorder. Of course, this is not the norm of the human body, where your immune system attacks your own cells. This is what? This is an answer to what? This is an answer to define an autoimmune disease. Your immune system is supposed to attack only non-self molecules, but is not supposed to attack self molecules. Your own molecules are considered self. Your immune system knows by heart your cells, and normally it should never be mistaken. It should always identify your cells as self and therefore not attack them. But how glomerulonephritis develops? It all starts by a kind of abnormality that occurs in the human body and that makes your immune system confused and consider the self molecules as non-self. So it all starts by a sore throat, and that sore throat is caused by a certain type of bacteria. And then like 2 weeks later, after the attack of sore throat subsides, not all parts of the bacterium have quit your body. And what happens is that some bacterial molecules get attached to your kidney cells. Some bacterial molecules get attached to your kidney cells. This is if I ask you about the pathogenic. They get attached to your own kidney cells. So suppose this is one of the kidney cells, and the immune system used to identify it as self. But after the sore throat, what happened is that certain foreign molecules or non-self molecules attach themselves to your cells. Where did they come from? They came from bacteria. So these are bacterial molecules. They are not whole bacteria, but they are fragments of bacteria. So now the immune system no more identifies this cell as self, but it identifies the cell as non-self, as a foreign cell, and therefore starts attacking it and causing severe inflammation, as shown by inflammation, as shown by redness, swelling, and pain in the kidney. And this damage results in hematuria. The next question will be, what is the relation between that autoimmune reaction and hematuria? So if you have an so this would be maybe, I don't know, question number 6. What's the relation between the autoimmune reaction that occurred and hematuria? So if there is an autoimmune reaction in the kidney, because of the previous sore throat and all this story of the bacterial molecules that have attached themselves to the kidney cells. So the autoimmune reaction will cause damage to the renal tissue, damage to the renal tissue. And that damage to the renal tissue is essentially because of inflammation. And when the renal tissues and renal structures are damaged, they no more look like before, especially the pores or the fenestrations. How would this damage be reflected on the pores? The pores will be larger than normal. So we would have increased size of the glomerular pores. So if the glomerular pores or fenestrations are now larger in size, they would allow filtration. They would allow filtration of large molecules and particles that were previously prevented. They would allow filtration or passage of previously prevented particles. Previously prevented particles. What are the previously prevented particles or structures? The red blood corpuscles that were previously prevented because of their large size, as well as the proteins, the plasma proteins. And the major plasma protein that can pass after the pores get wider is a plasma protein called albumin, actually because it is the smallest of the previously prevented plasma proteins, and therefore it will be the first to pass. So this is an answer to how does the autoimmune reaction cause hematuria and albuminuria. So we have two main symptoms in glomerulonephritis. The first one is hematuria, or the presence of red blood corpuscles in urine, and the second one is albuminuria or albuminuria, which is the presence of the protein albumin in urine. And both the appearance of RBC, the abnormal appearance of RBCs and the abnormal appearance of albumin in urine are due to enlarged pores. So is glomerulonephritis the only cause of painless hematuria? That's to say, hematuria without pain? No, there is another important cause, which is a systemic bleeding disorder. When we say systemic, we have to be very careful because systemic is not the same word as systematic. When we say systemic, we mean related to the body systems. And when we say systemic in medicine or in biology, we mean widespread. It might affect any of the body systems. And therefore, when you talk about systemic symptoms and signs, you mean that the symptoms and signs cover more than one system, and therefore they are more or less spread in the human body. But when we say systematic, we mean in an orderly manner or in an organized manner. For example, in medicine, we have to examine the patient in a systematic way, meaning that we have to follow a certain order during examination of the patient or during taking the history. So when we say systemic bleeding disorder, we mean bleeding that affects many parts of the body. For example, in systemic bleeding disorders, I can ask you about examples, for example, of bleeding that is systemic. So if the patient suffers, for example, from bleeding gums, if the patient suffers at the same time of bloody nose or blood coming out of the nose, which we call epistaxis, if the patient suffers at the same time from hematuria, so all body orifices or openings are giving out blood. Maybe in more severe cases, the patient has bleeding in the stomach, bleeding in the small intestines, bleeding from the rectal mucosa, bleeding from the anus. All this is an example of systemic bleeding disorders. Systemic bleeding disorder. Yes, but what are the causes of systemic bleeding disorders? They might be congenital, meaning that, for example, you are born with a small count of platelets, meaning that the platelets are subcellular structures or fragments of cells in the body. So if I ever ask you about platelets, we discussed this before. What are platelets? Platelets are fragments of cells, fragments of blood cells, and these fragments of blood cells promote blood clotting or stimulate blood clotting. They enhance blood clotting, okay? So these platelets in blood have a certain count that varies between 150 to 350,000. That's to say, you have to multiply by 1,000 per cubic millimeter of blood. So if you are born, for example, your bone marrow cannot form enough platelets so that at any time when you do a blood count, you have 100, only 1,000 of the platelets, then you would have systemic bleeding. So I might ask you, for example, what happens when? What happens when there is decreased platelet count? Of course, you should know the normal range. So what happens when your platelet count is 100 or when your platelet count is low? When your platelet count is low, of course, you would say a systemic bleeding disorder. But there is also another possibility for having a systemic bleeding disorder as a side effect of a medication that you take. For example, if a patient had a cardiac attack in which, for example, he had a clot in the heart, meaning that a part of the heart muscles were dead. A part was dead or became damaged because of a clot that closed the coronary arteries that supply. This is a blood vessel that we call coronary artery that supplies the heart with blood. So in such a case, in order to maintain the recovery of the patient, I will give him or her a medication to prevent clotting, which is an anti-clotting drug. Of course, usually the medical doctor prescribes the anti-clotting drug in a dose that does not have risky side effects. So here I might ask another question, which is what happens when the doctor prescribes an overdose of an anti-clotting drug, or what happens when the patient takes an overdose of an anti-clotting drug. In both cases, of course, there will be excessive bleeding. There are certain causes of hematuria that start painless and then become painful, like, for example, cancer bladder. Because in cancer bladder, you have a malignant outgrowth inside the cavity of the urinary bladder, but after a while, malignant cells invade and erode the blood vessels. And this is the cause of hematuria in case of cancer, because malignant cells, as you know, are invasive. The malignant tumor or the malignant mass is not well demarcated. It has the power to grow up rapidly and invade the surrounding tissues. So the malignant cells are invasive, meaning that they can invade and destroy the surrounding tissues. So they can destroy blood vessels and cause hematuria, but they can also destroy nerves and cause pain. So if I ever ask you about the hematuria that occurs in malignancy, why is there hematuria? Simply because the malignant cells invade and damage the blood vessels. And why is there pain in cancer bladder? This is just because the malignant cells can invade a nerve and cause pain, or invade the bones and cause bone pain. And now we come to something that is very important, which is a neurogenic bladder. One of the disorders that can occur, especially in diabetics, is the neurogenic bladder. And when we say neurogenic bladder, we mean that there is a bladder dysfunction or malfunction, malfunction because of nerve damage. So a neurogenic bladder means that your bladder is not working properly, the bladder, not the kidney. And why isn't the bladder working properly? Is it because it is inflamed? No. Is it because it has been invaded by malignant cells? No. So what is the cause? The cause is a nerve damage. We have two types of damage that might affect the bladder, and in order to discuss this, we will open a screen. If this is the urinary bladder, so we have two types of nerves that supply the urinary bladder. The black ones are sensory nerves, and those sensory nerves give information to the brain. They send info to the brain. They send info to the brain. What kind of info do they send to the brain? Several types of info, several messages, but mainly about the fullness of the bladder, about how full the bladder is, fullness of the bladder, and how full the bladder is. Of course, if the bladder is almost full, then these sensory nerves that I have drawn in black would give the patient the desire to micturate. The patient feels that he wants to go to the toilet and void. Of course, this interpretation occurs in the brain, but there are other types of nerve. Of course, let's first, there is another type of, or there are other nerves that I will be drawing in red and that give motor orders to the very thin muscles in the wall of the bladder to contract to help evacuating your bladder. Notice, of course, that the direction of the black nerves or the sensory ones is towards the brain. They are ascending upwards, whereas those of the motor nerves, which are the motor nerves, are descending downwards from the brain. We get motor orders to the urinary bladder to contract and evacuate the urine. So what you might be asked here is what happens when? So we have two types of questions here, or two versions for this question. What happens when? the sensory nerves of the bladder are damaged, for example, because of diabetes, or the motor nerves are damaged, the motor nerves, of course, of the urinary bladder. So, and each of these questions, so this is question A or version A, and this is question B or version B. And for each of these two questions, there are two parts for the answer. If the sensory nerves are damaged, so there is no desire to micturate because the patient does not feel the fullness of the bladder. So there is no desire to void or to evacuate the urinary bladder. But since the motor nerve is intact, there is intact emptying of the urinary bladder. So intact emptying. So although the patient does not feel that he wants to go to the toilet, yet he can on purpose evacuate the urinary bladder. But at the beginning of the disease, and when the patient is still not aware of the problem that occurred, the patient leaves himself or herself until complete fullness of the urinary bladder, which results in overcoming the urethral sphincter, and therefore dribbling of urine occurs. So there are drops of urine that leak from the urethral sphincter. On the other hand, in case B, if the motor nerve is damaged, the patient feels the desire to micturate. However, although he has an intense desire to micturate, he is unable to evacuate the bladder on purpose. This is, of course, a more difficult condition because the patient feels pain because of the extreme fullness of the bladder, yet the patient cannot evacuate. But in both cases, when the fullness of the bladder exceeds the capacity of the sphincter in the urethra to close the bladder, then the bladder will open and dribbling of urine occurs, or a few drops of urine will leak or be dissipated from the urinary bladder. The last disorder we will be talking about is senile enlargement of the prostate. And we will be covering the questions that you can be asked about senile enlargement of the prostate, or simply sometimes we say senile prostate. So the first question you might be asked about is, what is the prostate? What's the prostate? Okay. And then the second question might be question number 2. What happens when? Of course, when we talk about what happens when, then we are talking about the results or the consequences of the enlargement of the prostate. So the prostate, first of all, is, if you're asked about the prostate, then the prostate is a gland. First of all, it is a gland, and that gland has secretions that nourish the sperm. So it is a gland that essentially nourishes the sperms. But more importantly, more important than the function, is the location of the prostate. The prostate surrounds the base of the bladder, which we call the neck of the bladder. It surrounds the neck of the bladder. Why is this the most important thing? Because if the gland surrounds the neck of the bladder like this, if we look at the bladder from the side, a side view, you will see the prostate surrounding it like this. So at old ages, there is gradual enlargement of the prostate, which we call senile enlargement of the prostate. Senility means advancing age or old age. So the more the prostate enlarges, the more it compresses the urethra here. And if it compresses the urethra, then it is compressing the outlet of the urinary bladder. So the urinary bladder starts distending with urine. However, the patient cannot evacuate the urine. So what happens when the question number 2 is what happens when the prostate enlarges during old age? And in order to answer that question in an organized manner, we can open a new screen. So if you have prostate enlargement, which we call senile prostate enlargement, then there will be obstruction of the urinary bladder, obstruction of the urinary bladder outlet. And if there is obstruction of the urinary bladder outlet, then there will be retention of urine. Retention of urine. This is one result, retention of urine. And there will be pain during micturition because the outlet is very narrow. Pain during micturition. There will be incomplete evacuation of urine, incomplete evacuation of urine. And because there is incomplete evacuation of urine, then there will be frequency, meaning that the patient goes every now and then and has, just like in cystitis, and most of the time prostatic enlargement is associated with cystitis because of the retention. And retention of urine itself will, if it is chronic, if it is long-term, it will result in weakened muscles, and the weakened muscles of the urinary bladder would result in the hesitancy we have talked about. So all the symptoms of prostatic enlargement are mainly arising from obstruction of the outlet. Obstruction of the outlet leads to retention of urine and therefore to chronic dilatation of the bladder and therefore weakened muscles in the wall of the bladder. And since the muscles are weak, the patient cannot initiate the process of micturition and there is hesitancy. Of course, because the urinary bladder shows retention, then there is pain. And because there is incomplete evacuation of urine, then the patient will always have the need to go frequently to the bathroom. Now, of course, mostly the treatment of prostatic enlargement is through surgery or through surgery or laser. And now we are going to go rapidly over the questions that you might encounter that are related to diabetes. So the first question, for example, of course, would be about the normal range of blood sugar. So the normal range, so here, the normal glucose range in blood. The normal glucose range in blood is usually 80 to 120 milligrams per cent. Question number 2, you might be asked about hormones that control glucose homeostasis, and these hormones are glucagon, which raises the blood glucose level, and insulin that lowers the blood glucose level. You might also be asked about a third question about the mechanism of action of insulin. But first, before being asked about the mechanism of action of insulin, you might be asked about the overall effect of insulin. Of course, as you know, the overall effect of insulin is to diminish the blood glucose level. If elevated, it will restore it to normal. If normal, it will lower it down, and this would be risky to the patient. And it does this via three mechanisms. The first mechanism that is common to all body cells is that it stimulates uptake and oxidation of glucose by the cells. Uptake and oxidation, or you can say uptake and utilization of glucose by the cells. In liver cells, glucose so actually you are taking glucose from the blood and increasing its uptake into the cells. And that's why you are minimizing the amount of glucose or the level of glucose in the blood. Similarly, if you take here, what you take to all body cells is the required glucose, okay? But if you have surplus glucose, this surplus glucose will be stored in the liver as glycogen, which is the complex carbohydrate we've studied in the digestive system. This glucose, the surplus, might also reach the muscle cells and be stored as glycogen, or the surplus might again reach the fat cells and be stored as fat under the skin. So what reaches all body cells to produce energy for uptake and oxidation is the glucose we need for energy production. But the surplus reaches either the liver or the muscles or the fat cells under the skin. So in all these conditions, insulin is actually taking the glucose from blood and delivering it to the cells. So this is the mechanism of action of insulin. And then you might be asked about what happens in insulin deficiency, which is another way of saying what happens in diabetes mellitus. Of course, in insulin deficiency, the opposite will occur, meaning that if there isn't insulin and all these actions I've just been explaining depend on insulin, then there will not be uptake and utilization of glucose by the cells. There will not be uptake by the liver cells. They will not be uptake by muscle cells, and they will not be, meaning that there wouldn't be storage as glycogen in liver and muscle cells, and there wouldn't be deposition as fat under the skin. But is it enough to say this? Is it enough to say that if I don't have insulin, then there is no uptake and oxidation by the cells? There is no storage in the liver and muscles. There is no storage in the skin as fat? No. But we also have to say that if all these three actions do not occur because of insulin deficiency, then there will be marked elevation of glucose in blood, which is hyperglycemia. And this leads us to question number 5, which is to define hyperglycemia. Hyperglycemia means elevated blood glucose levels. These are the first 5 questions that you might be asked about diabetes mellitus. The next question that you might be asked about diabetes mellitus is about the types of diabetes. So the types of diabetes, we have type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 starts during childhood, and that's why we call it juvenile onset diabetes. And type 2 usually occurs in adulthood, and that's why we call it adult onset diabetes. But we sometimes call it based on the treatment. So in type 1 diabetes, the patient has absolute deficiency of insulin. absolute insulin deficiency, meaning that the pancreas produces zero insulin. And that's why this leads us to the third difference, which is that the patient in type 1 is totally dependent on insulin, and therefore we call it insulin-dependent diabetes mellitus. But in adult onset diabetes, the patient still produces some insulin, but that is not sufficient for the needs. So there is insulin deficiency, but it is not absolute insulin deficiency. It is relative insulin deficiency, meaning that there is some insulin that is produced by the pancreas, or sometimes even large amounts of insulin that are secreted by the pancreas, but that cannot cope with the needs of the body for a reason or another. And this is what we will be covering in question 7. And in type 2, because there is insulin in the body, the patient is not dependent on insulin. So non-insulin dependent diabetes. This is insulin dependent diabetes, but this one is non-insulin dependent diabetes. We might give medications that increase the efficiency of the insulin that is present, but this doesn't mean that type 2 never use insulin. In very late cases or in severe cases, they might refer to insulin. So this is question number 6. And then question number 7, why is there absolute deficiency of insulin in type 1? So question number 7, in type 1 diabetes mellitus, there is absolute deficiency, meaning that there is no insulin secretion at all by the pancreas, because usually it results from a viral disease that occurs during childhood, and that viral disease subsides, but there are certain viral molecules that attach themselves to the cells of the pancreas, and therefore the cells of the pancreas, although they are your own cells, they are now considered non-self cells, and they are attacked by your immune system. And since the immune system is attacking your own cells, so we can say that there is an autoimmune destruction of the cells of the pancreas that produce insulin, which are beta cells of the pancreas. And this leads us to question number 8, which is the pancreas is considered a dual gland. The pancreas is considered a dual gland. Of course, this is an easy question. It is a dual gland because it has an exocrine part that has ducts, and those ducts secrete their digestive juices that contain enzymes to reach the small intestine where they act, and it has an endocrine part, and the endocrine part consists of alpha cells and beta cells. The alpha cells secrete glucagon hormone, and the beta cells secrete insulin hormone. And as we said in the classroom, glucagon hormone and insulin hormone are antagonistic in function, meaning that glucagon raises the blood glucose level, insulin lowers the blood glucose level, yet although they are antagonistic in function, they coordinate to achieve homeostasis, meaning that they act according to the context. If you have a lowered blood glucose, then the pancreas will secrete glucagon. But if you have an elevated blood glucose, then the pancreas would secrete insulin. Then I might be asking you about the the islets of Langerhans, and the islets of Langerhans actually are nothing but the total of alpha and beta endocrine cells. We call them together the islets of Langerhans, according to the scientist who discovered them. And then question 8 can ask you about the insulin deficiency. I'm not sure whether it is 8 or 9, actually. Types of relative insulin deficiency. First of all, what is relative insulin deficiency? Relative insulin deficiency means that there is insulin secretion by the pancreas. Relative insulin deficiency means that there is insulin secretion by the pancreas, but if the secretion is adequate, then we wouldn't we will not say that there is insulin deficiency. So there is insulin secretion by the pancreas, but this secretion is not enough to normalize the blood sugar, is not enough to normalize blood glucose. Why isn't so? This is relative insulin deficiency. And now question 9, what are the causes of relative insulin deficiency? So the next question would be question number 9, causes of relative insulin deficiency and therefore of type 2 diabetes mellitus. So if I ask about causes of relative insulin deficiency, I'm actually asking about the causes of type 2 diabetes mellitus. So there are two broad categories or two broad reasons. The first one is the increased carbohydrate intake, because when you ingest carbohydrates excessively, your pancreas is secreting a lot of insulin that is not enough to cope with the high carbohydrate intake. So the pancreas becomes exhausted at the end of the day. And then the second one is insulin resistance, meaning that every cell has a protein molecule on its cell membrane, or several protein molecules on their cell membranes that are called receptors for insulin, or insulin receptors. And insulin cannot carry out its functions or its effects on the cells unless it binds with those insulin receptors. So insulin binds here with the insulin receptors, and when perfect binding occurs, there will be a response by the cell, and this response is insulin action, which is increased uptake and utilization of glucose by the cells, increased storage of glucose as glycogen, and so on. But sometimes there is insulin resistance, meaning that these receptors are fed up with receiving large amounts of insulin, and they decide to become irresponsive. Not only do they decide to become irresponsive, but actually they're all saturated with insulin. So any new insulin that will be formed will not find a seat to bind with or a receptor to bind with. And that's why this is the very weird case in which you find that insulin is not effective, and therefore we have hyperglycemia. But meanwhile, you have very high insulin levels in blood. So you have both together, hyperinsulinemia, because the pancreas is trying to secrete more and more insulin to control glucose. But meanwhile, there is hyperglycemia because all this insulin that is being produced does not find responsive receptors to bind with. And from there comes the paradox of having both. So whenever you have both hyperinsulinemia and hyperglycemia, then this indicates insulin resistance. And now we come to the maybe the last but most important question is how to deduce all diabetes symptoms from hyperglycemia. So how to deduce diabetes mellitus symptoms starting by hyperglycemia. So if you have hyperglycemia, let me start at the very left side of the screen. So we deduce all the symptoms of diabetes mellitus from hyperglycemia. So if we have, this is a very important question. Of course, I'll not get the whole question on a test or on a quiz, but you can use pieces of the answer to answer a smaller question. So when you have hyperglycemia, this means elevated blood glucose levels. And elevated blood glucose levels mean there will be increased load of filtered glucose at the glomeruli, increased load of filtered glucose at the glomeruli. If the load is markedly increased, then it would be more than the reabsorption capacity of the renal tubules, and therefore glucose will appear in urine because not 100% of it is reabsorbed. So you will have glucose in urine. Glucose in urine is glucosuria. And if you have glucose in urine, then this glucose will attract water and will prevent water reabsorption. It wants the water to stay with it in the renal tubules and not be reabsorbed because glucose attracts water. So it will prevent reabsorption of what? Reabsorption of water. So you will have large volumes of urine, large urine volumes. As I said in the classroom, we cannot say diluted urine because just like you have more water, you have more glucose. Large urine volumes, this is polyuria, and that's why the patient with diabetes suffers from polyuria. And if the patient with diabetes suffers from polyuria, this means that he loses a lot of water in urine. So the patient is all the time thirsty and has a dry mouth. Patient is thirsty and has a dry mouth, so he drinks plenty of water, and this is what we call polydipsia. So what is polydipsia? Polydipsia is drinking a lot of water because of thirst. But the patient not only suffers from thirst because of polyuria, but there is another important thing that is lost in urine, that is glucose, and glucose is lost in urine, which is the source. Glucose is the source of energy. So if you lose your source of energy in urine, then there will be diminished energy production by the cells. And if there is diminished energy production by the cells, then the patient will be fatigued, constantly fatigued, and there will be weight loss because the calories the patient is eating are being lost in urine. Okay, so here, how many symptoms have we said? We have talked about polyuria, which means increased urine volume. We have talked about thirst sensation. We have talked about polydipsia, and by the way, they are not synonymous. Polydipsia is the result of thirst sensation. We have talked about fatigue, and we have talked about weight loss, but there is another important thing. Since the patient is not benefiting from the glucose he is or she is eating, then there will be hunger, excessive hunger. And from there comes the famous paradox of diabetes mellitus, that the patient eats a lot always feels hungry because he is losing glucose and so a source of energy in urine, and meanwhile he is not gaining weight, he is losing weight despite this excessive hunger. Because when you are excessively hungry, you will eat a lot, and if you eat a lot, this is what we call polyphagia. So we have added two symptoms, the continuous hunger and the polyphagia. And sometimes the continuous thirst and the continuous hunger are the symptoms that indicate that the patient is, that first indicate that the patient is diabetic. There is another important thing that I haven't explained in class, but that is related, so I have to say it now, which is the renal threshold. Sorry. So what is the renal threshold? What is the renal threshold? We have said that whenever we have said that when the blood glucose levels are high, all these symptoms I've just explained will occur. But at which level do all these symptoms appear? We have said that the normal blood glucose levels range between 80 and 120. And then we have elevated blood glucose levels. But the elevation might be a mild elevation, so mildly elevated or severely elevated. Mildly elevated is between 120 to 180, and severely elevated will be more than 180. All the symptoms I have explained occur after blood glucose level exceeds 180. So 180 is the renal threshold. So the renal threshold is what? The renal threshold is a blood glucose level, and that blood glucose level, after being exceeded or when exceeded, will result in glucosuria, and if glucosuria occurs, then all the symptoms will occur. So again, what is the renal threshold? The renal threshold is around 180 milligrams per deciliter. It is a blood glucose level that, when exceeded, will result in appearance of glucose in urine, and therefore all the sequence of symptoms we have seen. So what about this value? A patient who has a value of blood glucose level between 120 and 180 will have increased filtration of glucose in urine, will have increased filtered glucose. But however, and despite this, there will still be 100% reabsorption. This means that the kidney can cope with increased loads of filtered glucose as long as the filtered glucose comes from a blood level of glucose that is between 120 and 180. So what happens is that it's true that the blood glucose level is elevated above 120. It's not a normal blood glucose level, but the kidney tries to conceal or to hide the problem. And despite having increased filtered loads of glucose in the PCT and in Bowman's capsule first, and then in the PCT, it tries or it succeeds in 100% reabsorption. Therefore, there will be no glucose in urine, and there will be no symptoms at all. No glucosuria means no symptoms, and the patient does not show symptoms. And this means that if your blood glucose level is elevated above normal, but lower than the threshold, which is 180, you might feel fatigued, you might feel a bit uncomfortable, but you will not show the full-blown picture of diabetes, just because you still haven't yet shown a glucosuria in urine, which is the phenomenon that is responsible for all the symptoms and signs of diabetes. Thank you guys, and see you at school, inshallah, on Tuesday for 10B and on Thursday for 10A. If you have any questions, you can send me on WhatsApp. Bye.